Regards, sir, to all the audience. My special regard to Dr. S. Arora, sir, and the organizing committee. My talk of today is ECG in diabetic heart disease, coronary and non-coronary. The present talk would be revolving around the following topics: cardiovascular disease spectrum in diabetes mellitus, diabetic patients' need of earlier detection of ECG changes, pathological changes in the heart, including at times aortic stenosis, ECG recording in diabetic patients, pathophysiology of ECG change in diabetes. These points should be covered first in order to give the clear concept of the topic what I am going to discuss. The next ones would be important ECG alterations, QT versus QTC interval, prognostic ECG parameters, detection of silent ischemia in diabetic patients, and ECG changes to the diagnosis of STEMI, cardiomyopathy, and acute heart failure. At the end, I am putting some examples of the ECG for proper understanding. By the term diabetic cardiovascular disease or heart disease, I mean to say there are three spectrum: coronary artery disease, diabetic cardiomyopathy, and heart failure. And the root factors in all the three may be atherosclerotic macrovascular dysfunction, coronary microvascular dysfunction, cardiomyocytes changes. And at any time, either of the three may lead to cardiac arrhythmias, and very occasionally the condition may be associated with the aortic stenosis. Now we have to select the group of the patients for whom we shall be recording the ECG changes. Three subgroups are categorized to have resting ECG to reveal the ECG abnormalities at the earliest stages: diabetes, diabetes with hypertension, diabetes mellitus with cardiovascular risk factors such as old age group, male sex, hypertension, lower HDL cholesterol, high BMI, and smoking behavior, etc. We shall record the ECG under three heads, what I have just enumerated. Pathological changes in the heart associated with diabetic mellitus are very essential to be understood. First, the premature atherosclerosis, structural and functional changes in the microcoronary circulation, fibrotic changes, especially in the basal part of the left ventricle, even when cardiac involvement is not yet evident, reactive hypertrophy, usually left ventricular, increased accumulated precardial fat attributes to the progression of coronary arteriosclerosis, and is an independent risk factor for stenotic coronary artery disease. These factors must be kept in mind to understand the changes to be described on ECG later on. Aortic stenosis in diabetic mellitus, there are two factors, mainly factors responsible for that. Cardiovascular atomic neuropathy, together with the diabetic duration, has been demonstrated as the main predictor of reduced aortic distensibility in type 2 diabetes, and therefore it is associated with a significant reduction in the elastic property of the aorta. Combined together with the fibrotic changes, especially in the basal area of the left ventricle or ventricle, better to say, have frequently been observed in diabetic patients even when cardiac involvement is not yet evident. So on one hand, there is a alteration in the aortic distensibility, reduced aortic distensibility, superseded with the fibrotic changes, would lead to the aortic stenosis in some percent of the cases. The ECG and diabetic cardiovascular disease. The ECG is a quick, non-invasive diagnostic and research tool for the early detection of cardiovascular changes or disease in diabetes. This may also point towards the subtle changes even in subclinical diabetes mellitus. Subtle ECG alterations may be the only way to diagnose silent myocardial ischemia and even early cardiomyopathy. Here to say that overt cardiovascular disease associated with diabetic mellitus may be diagnosed on ECG very easily, but subtle changes before the evolution to the final evolution of the cardiovascular disorder associated with diabetic mellitus may be difficult. So this would be made easier by the earlier observation of the subtle changes on ECG associated with diabetes mellitus. ECG recording in diabetes mellitus, as usual, cardiac rhythm, heart rate, QRS axis, QRT angle, presence of atrioventricular conduction, conduction defect with bundle branch block, sort of defect like the right bundle block, left anterior facial block, left bundle block, signs of the MI, especially previous or occult, left ventricular hypertrophy, repricing abnormalities, ST changes, and the QTC corrected one. This part of pathophysiology of ECG changes in diabetes, to my opinion, is having paramount importance to be understood. There are few factors responsible for that. There is alteration in the membranous part of the cardiac myocytes. The metabolic changes are responsible for the same, like the reduced glucose oxidation and increased fatty acid oxidation with mitochondrial dysfunction. With this sort of the changes over the myocytes would lead to some sort of alteration in the myocardial membrane with down regulation of the potassium depolarization current, especially during the phase 2 and phase 3. During either the phase 2 or 3, there is a reduced amount of the leakage from the inter compartment to the extracellular compartment. Transfer process is somewhat defective, leading to down regulation of the potassium depolarization current, which is responsible for the depolarization sort of the abnormalities like the ST and T changes and QTC interval, etc. Heightened metasympathetic regulation of the heart rate with contractility may be responsible for some of the changes. So this sort of understanding we should have at the baseline. ECG changes in diabetes. Resting ECG can be within a normal limit even in advanced stage of coronary artery disease, but ECG changes may present in asymptomatic cases. Just a controversy, just the reverse sort of the changes. Normal ECG may be in the advanced cases, and the subtle cases may show the ECG changes. Just we have to catch up by ECG recording. Down regulation of potassium depolarizing current will be reflected in the form of QTC prolongation, QTC dispersion, non-specific ST and T changes. This organized sympathetic regulation of heart rate could be reflected in the form of sinus tachycardia, change in the heart rate variability, spatial curiosity T angle. This spatial curiosity T angle is more or less equivalent to QTC interval for the practical purposes. Miscellaneous changes may be in form of left ventricular hypertrophy, increased amplitude of depolarization waves like the QRS, shortened ventricular activation time, non-specific left atrial enlargement, and episodic atrial fibrillation. This episodic atrial fibrillation is not good in diabetic populations. It is having the bad prognostic sign value. Abnormality of central nervous system versus some of the depolarizing abnormalities. Anderson described a pattern in which T waves are deeply inverted in the left precordial leads, but the tall T in the right precordial leads. Several publications include examples of deeply inverted symmetrical T waves during treatment of diabetic acidosis, even at a time when the potassium abnormalities were not present. Here I want to say that some cases I have witnessed to see the deeply inverted T waves over the left precordial leads with the tall T waves over the right precordial leads. Initially, I was not in position to analyze them, but now I can sense that they are due to the alteration of the central nervous system. This alteration or abnormality of central nervous system may cause the depolarization phenomena to occur from the endocardial rather than to the epicardial surface. That's why this sort of changes, if they are associated with much sort of the transmural dispersion, there may be the deep inverted T waves in the left precordial leads and the tall T peak in right precordial leads. QT and QTC interval. Female sex, higher value of HbA1c, systolic blood pressure, nephropathy associated with increased risk of prolonged QTC, where physical activity and normal body mass index are protective values. Here I want to give a message that even the bed or other bed associations are present with the QTC prolongation, or one should not fear of, one should get the treatment properly, and also to keep the body mass index within normal limits with regular physical activities going on. The QTC interval can be used to diagnose cardiovascular autonomic neuropathy with reasonable sensitivity, specificity, and positive predictive value. Correlation between QTc and the amount of coronary calcium is a well-known fact. From QT interval parameters, both the QT dispersion, the main difference between the QT maximum and the QT minimum interval in all the ECG, and the QT maximum may be determined. All these factors would be telling us the occult history behind the progression of subtle changes in a diabetic patient to be recorded on ECG. The main discussion would be to gather the prognostic ECG parameters in such cases, on which we can be, our ears must be alert. We should say we should be in a position to say that patient is having the bad prognostic signs on ECG. The first of all is the QT and QTC dispersion. QT dispersion is very important to be understood here. Cardiac autonomic neuropathy with prolonged variability in QT of both high incidence of the sudden death, asymptomatic episodes of atrial fibrillation with some arrhythmias progression, may be subsequently with higher rise in death. Increased heart rate and QTc intervals seem to be associated with total mortality and morbidity. Hazard ratio 1.3-fold increase per 10 beats per minute. And left ventricular hypertrophy is significantly associated with the prolongation of the QT interval. Again, it is a known fact. The spatial curiosity angle quantifies the deviation between reduction of the ventricular deposition and reposition and is a marker of arrhythmia variability. Detection of silent ischemia in diabetic patient. Resting ECG, stress testing, exercise testing, thallium scintigraphy with dipyridinol is performed if exercise testing is not possible or inconclusive. Perfusion imaging may be helpful if required. The use of exercise-related screening before an exercise training program for patients with asymptomatic type of diabetic mellitus might be justified, but it remains unproven. ECG measures of cardiac autonomic neuropathy. Baroreceptor dysfunction and disturbed heart rate variability are most commonly used method to assess cardiovascular autonomic neuropathy. Reduced nighttime vagal modulation of the heart rate, persons with high resting heart rate and low heart rate variability, QTc interval can be used to diagnose CN with reasonable sensitivity and specificity and positive predictive value. Heart rate response through deep breathing, Valsalva maneuver, postural changes, hand gripping may be recordable through an automatic device. The neuropathic stress is a modern indicator based on the measurement of the sweat production after exposure to thermal foot plate. ECG changes to the diagnostic STEMI. Peaked upright T wave is the earliest abnormality with STEMI. ST elevation in 2 or more anatomical continuous leads, like the in males more than 40 years of age, more than equivalent of more than 2 mm in lead V2 and V3, and more than 1 mm in all other leads. In males less than 40 years of age, ST elevation in lead V2 and V3 each more than 2.5 mm. In women, ST elevation more than 1.5 mm in leads V2 and V3 and more than 1 mm in other leads. New pathological Q wave and also the new onset of left bundle branch block. Just in brief, I am covering all the things. At the end, I will discuss in details. ECG change in dilated cardiomyopathy and or heart failure. An ECG should be obtained to look for the evidence of ischemia, ST and T wave abnormalities, hypertrophy, especially left ventricular hypertrophy, plus minus atrial enlargement, poor R wave progression, previous evidence of myocardial infarction Q waves, conduction blocks, intraventricular conduction delay, later to QRS, and arrhythmias supraventricular and ventricular. A male, some examples of the ECG. This patient has been under my treatment since last rather more than 15 years. This patient, whenever I record his ECG, his QRS axis lies in between the 30 degree, minus 30 degree to minus 45 degree, and at times 60, minus 60 degrees. So there is a variation between the up to the in between the left axis deviation towards the left anti-fascicle block. This left anti-fascicle block is a very short of the very known well abnormality in case of diabetic mellitus, and this such persistent changes as I am seeing in this patient from the very beginning, and there is no alteration. Only I advised him, apart from the treatment of diabetic mellitus, I advised him to not to increase the weight. His weight is normal, and to have regular exercise. And since last 15 years, he is having 1 hour or 45 minutes exercise walking daily without any sort of interruption, whether it's the rainy season or the winter season. So if one is having the regular exercise plus body fitness in form of the weight, he has done a lot for himself. This ECG again is of importance. This middle area diabetic patient with recurrent fainting episodes lasting for 3 days duration. In this ECG, we are seeing the complete right bundle branch block pattern over the V1 with deep S wave over the anterolateral chest leads. And the pattern is stimulating left bundle block in lead 1 and AVL with left axis deviation, and S waves in lead 1 tends to be very small. P wave must be T wave with somewhat prolonged PR interval. So this case is having the prolonged PR interval plus musculating bundle block. Ultimately, the patient required the permanent pacemaker, and we have investigated further on, and ultimately he needed the revascularization therapy. This sort of the musculating bundle block is said to be present on ECG when there is diffuse conductive disturbances due to any sort of the illness over the left ventricle, or there is a 3-vessel disease. In this patient, there was the evidence of the 3-vessel disease, and we have accordingly modified by the surgical by the revascularization processes. A male aged next ECG, the male aged 76 years with a long history of diabetes mellitus. This sort of the abnormality in the form of complete right bundle block plus left anti-fascicle block, bicircular block is very common. Is very common in diabetic heart disease, and at times they may need the permanent pacemaker if the patient shows the phenomenon of the Stokes-Arnold syndrome by trifascicular conversion to complete heart block. So we have to be precautious in this group of the patients. This ECG. Recently, I have come to see this ECG. This ECG is a 72 years male diabetic patient with documented hypoglycemia just 4 days back, and he felt better after glucose intake orally. This ECG shows atrial fibrillation with high left anterior fascicular block with intermittent ventricular extrasystoles, curable with query aberrant interval conduction, poor R-wave progression, directed with clockwise rotation. This atrial fibrillation is not a good sign with the diabetic patients. Whenever we see this sort of the changes over ECG, our ears become alert, we become alert, and try to give the medical advice in a proper way. To we can't usually this atrial fibrillation are episodic normally, but we have to give the medications to prevent them the episodic episodes, and we have to medicate the patients or treat the patient accordingly to have the good glucose control, diabetic control. It is not the end. Rather, at the end, I would go to some details. At the end, I wish to express that there are 3 main spectrum manifestations of cardiovascular disease associated with diabetic mellitus: coronary artery disease, diabetic cardiomyopathy, and heart failure. But becomes essential to recognize early and subtle ECG changes at the earliest stages in diabetic population. Just a short of the discussion over this master class, I would like to say some things. There are 2 groups of the cases. There are 2 groups of the changes over ECG. Number 1 group of the changes are associated with the gross manifested disorders like the coronary artery disease, diabetic cardiomyopathy, and even the heart failure. And the second group of the cases are seen in subtle forms, which may appear years before the actual onset before the actual onset of the ECG or diabetic heart disease. So there is credit if we catch the earlier onset of the ECG changes before ensuing or before passing the coronary artery disease or diabetic cardiomyopathy or the heart failure, the credit goes to us, and we can save the patient life by taking the appropriate preventive measures and treatment accordingly. The ECG changes, earlier ECG changes or subtle ECG changes can be understood better in a better way by two phenomena, rather three phenomena. There are some changes over the cardiac myocytes membrane, which keeps the potassium regulating system in a downward manner. That means there is a leakage of the potassium from the intracellular compartment to the extracellular compartment during the phase 2 and 3 of ventricular deprivation becomes less. That's why there is a change in the QTC interval and also the ST segment and the T wave changes. They must be caught. They may be showing the bad prognostic signs. And next point is that if there is a associated cardiovascular autonomic neuropathy, there may be sympathetic changes linked to the increased heart rate with the more sort of change in the QRS complex, or the fate changes may be there. So whatever the changes are seen in subtle forms associated with diabetes mellitus, they must be caught earlier. What I want to say, earlier catching means we can prevent the progression of the disease possibly, or we can do whatever best for the patient. And it's very easier to recognize the overt changes. So I'm not discuss the overt changes in so much of details. Just I have tried to keep myself limited to the subtle changes rather than the gross changes. Though I have discussed the gross changes, no doubt. So the term diabetic heart disease, coronary and non-coronary, as my topic says, is a vast topic. Is having a vast spectrum. Over the surface of sea, there are floating boats easily seen. But underneath the water of the sea, depth of the sea, there are so many things in the form of the subtle, especially diabetic heart. We have to catch those changes. Very important changes. A few words about the QTC interval. This QTC or QT interval, better to say, is the measurement of the total ventricular deprivation and the ventricular deprivation. The main changes are in the ventricular deprivation responsible for the QT prolongation. Whenever there is a some sort of the distance measurement or the duration progression of the deprivation waves or the pattern, the QT interval tends to be prolonged. And whenever there is a rest to the myocardial muscles for even a few fractions of the seconds, the chance of the ventricular arrhythmias may be on the plus side. That's why we say that the QTC interval is the thermometer of the changes which may lead to the ventricular arrhythmias. And QRST angle. QRST axis is the ventricular deprivation axis, and T is the deprivation axis. Normally, the interval in between the two, in terms of the degree, is 45 degree to 60 degree. Sometimes they say. If the interval becomes prolonged, what does it mean? It means that the ventricular deprivation is somewhat lagging behind than the ventricular deprivation, and this lagging behind may keep the ventricular myocardium somewhat in active stage if there is a predisposition of some sort of predisposition of the ventricular arrhythmias development, or the ventricular arrhythmias may develop as de novo at times. So this is the significance. So QTC interval, your QRST angle differences, more or less they denote the same things for the purpose here. So it's very important to be understood here. ST and T changes may be non-specific in nature, Actually, what happens that during the ST segment recording, especially it is due to the ionic. So better to now stop my talk. I think the time is on. So with these words, just I say thanks to all of you for patience hearing.